Welcome to this case review on Volume Guarantee, or VG, ventilation mode, presented by Dr. Salem Keshba. This video will explore a specific clinical case to deepen our understanding of VGAC mode. Can you 1. What abnormal ventilator finding is demonstrated on this screen? 2. What is the most likely explanation for the elevated respiratory rate? 3. What differential diagnoses should be considered? 4. What clinical and ventilator parameters would you monitor to assess the infant? 5. Would you increase ventilator support in this situation? Why or why not? 6. Based on the displayed data, is this infant potentially approaching extubation readiness? We are reviewing a case presenting with low peak inspiratory pressure, or PIP, but a high respiratory rate, or RR, in VGAC mode. The patient's weight is 2.6 kilograms, and the set respiratory rate is 40 per minute, but the measured RR is 72 per minute. Crucially, the expired tidal volume matches the target tidal volume of 10 milliliters. We also observe that PIP is very close to PEEP, creating a near-zero pressure gradient for gas delivery. The problem lies in the contrasting parameters. Low PIP, almost equal to PEEP, suggests minimal pressure delivery, yet the measured RR of 72 indicates active breathing by the infant. The critical clue is that the target tidal volume is still met. The infant is spontaneously breathing effectively, despite the low ventilator support. When the target tidal volume is met, it means gas exchange is effective. The ventilator reduces its effort by lowering PIP when the target is reached, demonstrating the VG algorithm is functioning correctly. This suggests the infant is driving most of the ventilation, achieving the majority of the tidal volume independently. This combination signals respiratory improvement, with the ventilator acting only as a safety net. The most likely cause for this presentation is strong, spontaneous breathing effort by the infant, a common and physiologically expected sign in an improving preterm infant. The VG algorithm responds by measuring the expired tidal volume, detecting that the volume target is met, and automatically reducing PIP until it falls close to the PEEP level. This results in minimal ventilator work and an elevated measured respiratory rate due to the infant's spontaneous breaths. When evaluating low PIP with high RR in VG mode, the differential diagnosis begins with the most likely cause: strong spontaneous breathing. Other causes to consider are pain or agitation, which would lead to tachypnea and distress. Excessive trigger sensitivity or auto-triggering may also mimic this, so checking waveforms is essential. Excluded causes, if the tidal volume target is met, include ETT leaks or flow sensor malfunctions. Also excluded is hypercapnia-driven increased work of breathing if ABGs are normal. Monitoring should focus on continuous vital signs, including SpO2 and respiratory effort. Key ventilator parameters are real-time PIP, PEEP trends, and tidal volumes. Airway integrity checks include ETT position and checking for leaks or blockages. We should monitor blood gases, especially PaCO2, and obtain a chest X-ray if indicated. Finally, conduct a clinical assessment for signs of distress and check the flow sensor and circuit integrity. If the ABG is normal and the patient is clinically stable, no ventilator adjustment is needed. Continue clinical monitoring and assess for extubation readiness. Plan for an extubation trial, considering CPAP or HFNC. If tachypnea persists or there is concern, first assess and treat pain. Check for auto-triggering, verify ETT position, and evaluate the flow sensor. If concerns remain, obtain an ABG and chest X-ray. If PaCO2 is elevated, increase support. The key learning point is that a low PIP with an adequate tidal volume in VG mode typically signals effective spontaneous breathing and minimal ventilator support. This is a sign of progress, not malfunction. However, always verify with an arterial blood gas, or ABG, as a rising PaCO2 would change the interpretation. Low support and strong spontaneous drive mean proactively assessing for extubation readiness.